Welcome, everyone, to this particular edition of our series on building resilience and well-being in times of uncertainty. Before we go ahead with the topic for today, which is looking at mental health in aged care facilities, I'd like to acknowledge that I'm coming to you today from the lands of the Wurundjeri people of the Kulin Nation, and I take this opportunity to pay my respects to their elders, past, present, and emerging. The discussion today is a topic that many of you have heard me talking about, the inextricable linkage between financial, physical, and mental health and well-being, and the aspects of affordable access to mental health for all Australians. So today we will be focusing on residential aged care and geropsychology, and we have a wonderful participant, Professor Sunil Bhar. So without further ado, I hand over to you, Anna, for this webinar.
Thanks so much, Vinita. And I'm definitely looking forward to this discussion. I think there's a few of us who, I'm sure many people in the audience who haven't heard of this topic before, and it might be a lot of new perspective, a lot of new ideas that we haven't even considered. And on our panel, as mentioned by Vinita, we have Professor Sunil Bhar, who is the director at Swinburne University's Wellbeing Clinic for Older Adults. And I'll hand over to you, Sunil, to introduce yourself in a little bit more detail, because I think it'd be great to firstly just hear a little bit more about your experience and your background, but also really set the context as to why this is an important topic for us to be discussing today.
Yeah, great. Thanks very much, Anna and Vinita. I really appreciate the invitation as well. It's always dangerous to ask an academic to talk about themselves and their research because we're very well practiced at that. So I'll try and keep my comments short, and I would really appreciate your questions and your insights as well. So I came to the area of late life psychology quite late in my career. I had completed my PhD and had the opportunity of working abroad in a lab that was focused on understanding whether psychological therapy was effective for older adults. And I discovered that a lot of the training that we've received as psychologists was not really relevant to older adults. We didn't really know how to deal with the complexity that came with late life, whether it be physical illnesses, like you've mentioned, Vinita, or cognitive impairment, financial challenges, differences in family dynamics, and how that all interacted with mental health. And so I came back to Australia filled with an enthusiasm about how to develop a service for older people with all of these insights, and discovered to my surprise that there were very few opportunities for people to get meaningful and dignified mental health services in late life. And this was quite pronounced if you lived in a nursing home, or what we now call a residential aged care home in Australia. Very few services were specializing in delivering psychological care into aged care. And so we developed this clinic that you mentioned, the Swinburne Wellbeing Clinic for Older Adults, to do two things. One, to bring this kind of care into residential aged care homes, and two, to provide training for our students so that when you and I are living in nursing homes, we've got a competent and trained workforce to address our emotional care needs. And because I work at a university, I'm also very heavily involved in research. And so along the way, as we've been developing this clinic, we've also had the opportunity to get grants and to do research studies and supervise PhD projects, all to understand how can we provide meaningful and effective services to help the emotional support of older people, particularly those living in care. And one of our earliest insights was that if we were to deliver proper service into residential aged care, we couldn't do so on a one-to-one basis. We had to expand our service to address the needs of the families as well as the professional carers. And so that's kind of giving you a bit of a background on my services. I'm a professor that does research, but I'm also a clinical psychologist, very involved in the treatment of people, and a director of the clinic trying to curate a service that tries to make a difference in the lives of older people living in care.
It's a great introduction, and thank you for sharing that. I think it's something that I'm sure, we've got an aging population. There's many of us who have experiences with, grandparents who are in aged care facilities, or parents, and I think that's something that potentially gets overlooked because it's a little bit uncomfortable, or it's a bit, people don't want to think about themselves in the future either. So it sounds like you're really setting the foundation for, like you said, the future generation who'll be helping to care for the new generation of older people. And it'd be good to understand, in terms of, from your experience, what do you see the current state of affordable access to mental health care for older Australians?
Affordability of any healthcare is very complicated as you start to think about the heterogeneity or the differences within the older population. So, if we define an older person as 60 plus or 65 plus, depending on your context, it's possible, isn't it, at a stretch of imagination to include a grandparent, a parent, and a child within that definition. And so, the minute you start asking questions about older people, we're doomed to generalize, we're doomed to stereotype. Right. So it's the complexity that tends to be overlooked. So the affordability of healthcare, including mental health care, depends. It depends on what kinds of complexities you present with. It depends on where you live. And it depends on how much knowledge you have of the system. So I'll just go into each of those in more detail just to try and unpack that question. So if you live in the community, you have access to a lot of free services. In fact, we have a system in Australia where we provide mental health support for free through our publicly funded systems, such as the Older Adults Mental Health System. And often those services are provided for free if you have a severe mental health problem, such as schizophrenia or more generally psychosis, or if you have bipolar disorder, or if you have depression with suicidality. Often that's when these big government services become very relevant because they can not only provide you with one-on-one therapy, but they can also provide case management and curate the various aspects of your life that require care. Now, if your problems are not as severe, often you don't meet the eligibility criteria of this free government service. And then often your care is directed by GPs or general practitioners or through community counseling centers. Sometimes we call them community health care centers. And that's where the affordability can vary. On the one hand, it can be free if your service is provided entirely through the Medicare system, or your service might only be partially rebated. And that's where you get variation, right? Every session might cost you between $20 all the way up to $100, depending on whether the rebates cover the entire cost. However, if you live in a residential aged care facility or a nursing home, the picture becomes more complicated because it's not easy anymore, is it, to travel out to your GP clinic, to go to one of these community centers. And when you're living in care and you're highly dependent on other people for that care, then you're dependent on in-reach services. You're dependent on GPs visiting you, or in the case of in Australia, of mental health services visiting into aged care. And since 2018, the government has funded primary health networks, or PHNs, to commission services to provide psychological care directly into residential aged care centres. And this has been a fantastic development in Australia. In fact, never before have we had such free and affordable, accessible mental health care for people living in nursing homes, right? The problem, however, is that we're not doing enough. There are close to 3,000 aged care facilities or aged care homes in Australia, and only about half of them currently have arrangements with PHN commissioned services. So while we can say that the services are affordable, we're still trying to work out how to make them more accessible and more widely available. Now, because the system is fragmented, it depends on whether you live in the community as opposed to residential aged care. A lot of people don't quite know how to navigate through this system. It's very confusing. And once you add on top of the lack of awareness problems such as physical illnesses, cognitive impairment, people simply don't know where to go. And often the front door tends to be community organizations such as Dementia Australia, and they can provide a lot of information to help guide people through the maze so that they get the care that they need. In fact, Dementia Australia provides free counseling support to people living with dementia as well as their family carers and professional carers. So that might be a useful organization to tap into. Now, I can continue, if I can, to now talk about the private sector, which is even more complicated. The private sector is made out of a heterogeneous group of mental health clinicians that go by various labels, such as psychotherapists, social workers, counselors, occupational therapists, and psychologists. Some of these people are registered and accredited, some of them are not. And it can be even more confusing for the consumer to try and work out who to see. For example, if they see a psychologist, Medicare does provide some rebates for that session. The rebates can go up to about $145 or so. And currently, the recommended rate for outpatient private psychology services is close to $320. So if you do the maths, there's still about $170 out-of-pocket expense. So when you talk about the affordability of mental health care, it's a confusing question to answer because it depends on where you live, on what kinds of services you use, and whether you're dipping into the public sector or the private sector.
That's a really helpful overview, and it would be good to understand what the typical mental health conditions you kind of see, or what is most prevalent in later life?
Okay. So again, that's a loaded question because we don't often assess for mental health conditions in later life. So when these broad surveys are done by the Australian Bureau of Statistics and through well-being surveys, generally they tap into 3 or 4 different mental health conditions, as they call it. There's, of course, depression and anxiety. There is psychosis and there's substance use. And so those are probably the 3 that we know most about in later life. The data are conflicting about the prevalence of mental health conditions in later life. Some surveys suggest that as we get older, our mental health improves, and some surveys suggest the absolute opposite. And this is quite baffling because you've got surveys that seem to indicate that mental health improves on the one hand and it becomes worse on the other. The puzzle is explained to some extent when we start to ask the question, who are you actually serving? Are you serving people who live in their own homes, or are you serving people who are on aged care service benefits of some kind, whether they live in the community or whether they live in residential aged care? As soon as you move from people who are living independently in the community to residential aged care, the prevalence of mental health increases substantially. In fact, it's not unusual to see some surveys suggest that up to 60 or 70% of people living in residential aged care have significant mental health problems. 60 to 70%. Now, when you contrast that to people living in the community, it tends to hover between 15 and 20%. So it's more than double the rate of mental health concerns in the community. So this is one of the big puzzles that we now are trying to unpack. The question of how ill are older people tends to be a bit complicated to answer because the setting matters. When you survey people in residential aged care, when you survey people in hospitals, when you survey people who are receiving in-home aged care benefits, because they tend to be more frail, because they tend to be more dependent and ill, the mental health conditions seem to be more prevalent in those populations compared to older people who are living independently in the community.
That's a really helpful overview and quite some surprising stats there, or maybe not surprising as the way you've broken it down, but quite stark differences there between those living in the residential aged care compared to living in the community. And it sounds like there is certainly something to be said for people being able to maybe be connecting with other people or having access, being close to friends or family members, or even just I suppose the care that they're accessing. And the it's a challenge though, as you mentioned with the survey data, given it's always the challenge with data where the way you ask the questions and who you ask, and are you asking a group of people that are particularly unwell or having particular challenges compared to those who are fit enough to do the survey in the community. It's really challenging, and I'm sure especially in the academic space, you do these studies and it's really challenging to know what's the true insight. But I think it's really helpful to better understand that. And I think that the next question leading on from this would be good to understand what some of the treatment models and services are for both the groups that we mentioned, and what you tend to see works well, or what you're learning about this.
Yeah. So this is an interesting question because we haven't been asking this question enough. What are the treatment models that are relevant to older adults? And given the heterogeneity in older people, in terms of them spanning, 3-4 decades, if you go by the definition of 60 plus, on the one hand, you could say that whatever works for younger adults will work for older people. So let's compare the 45-year-old person who's going to work every day, etc. Let's compare the 67-year-old person who's going to work every day, etc. There's nothing really different about their lifestyle. Maybe one person's a little bit more tired towards the end of the day, but essentially the treatment is the same. They're both able to focus on their own psychology. They're able to reflect on their lives. They're able to attend outpatient appointments. They're able to implement, whether we call it homework assignments or home assignments. They're both fit and able to do all of the things. Now, the minute you start adding to the picture illnesses such as physical health concerns, people start to use walking frames, they start to be bedridden because of physical complaints, they start to become more frail and experience hearing and sight difficulties. Suddenly you start to think, well, maybe this individual going through these changes isn't able as easily to come to an outpatient appointment. Maybe the clinician needs to modify their practice to be home-based. So the clinician travels to the patient. And when you add cognitive impairments to the mix, someone who's not able to remember why they're there with you, they're not able to remember facts about their past, the clinician might think, well, how can I deliver therapy to this individual if they don't even remember what we spoke about the previous week? So that this is where the treatment model starts to change and shift. And there are different modifications that we've started to make to the traditional psychology treatments that we would prescribe for younger adults to older adults. For example, we'd include families more into the treatment so that the families can become a sort of a appendix, if you like, or a memory strategy for the older adults, so that between sessions, the families can take over some of those therapy strategies. We might want to slow down therapy so that we're not using language in a way that feels too burdensome for the older person. We slow things down. We have shorter sessions, right? We might want to work around the individual, particularly if they're at a state where they can't really have a dialogue with the clinician. So instead of providing one-to-one therapy, we might start to work with the professional carers so that we can start to train the carers to deliver a certain kind of care to the individual. And as soon as you start to stretch treatment in this way, we hear things of adapting psychological therapies to older adults. So the dominant psychological treatments at the moment for a lot of different conditions is cognitive behavioral therapy, acceptance commitment therapy, mindfulness strategies, and a whole bunch of other smaller therapies, right? But the one therapy that we use a lot for late life depression is reminiscence therapy. And this therapy is unusual compared to all of the other therapies because this therapy was designed specifically for older people rather than for younger people. Whereas all of the other therapies were developed with younger people, your so-called 23-year-old university-going adult, right? Ready and motivated to take treatment. Reminiscence therapy, on the other hand, was developed for older people who have a yearning to review their life course, who are at the stage of life where the past is actually longer than the future, right? And who've reached a level in their life where they feel the need to not only reflect on what's happened, but to understand what's happened in the past that has got them to their present state. And sometimes older people feel the need to leave a legacy. And so reminiscence therapy is an interesting way, in a very dignified way, of not only learning about the individual's life story, but giving them a sense of what their life has been about and helping them to connect to their values and to their identity. And we found, and research has basically replicated this over and over again, that reminiscence therapy is one of the most effective treatments for late life depression across the spectrum of people with physical illnesses and cognitive impairment. And so this is one of the therapies that we try and train our students and our clinicians to use. And it has a lot of validity. What I mean by that is that people understand why this therapy could be effective for older adults.
That sounds really impactful and powerful in terms of how specific it is. And it sounds like it's really come from research to understand, if you had the same therapy for a 20-year-old, it just doesn't make any sense because they're just going through completely different, they might be stressed about the future in a different way that someone's looking back at their life. And it sounds like that has a lot of amazing potential and could be really both helpful in terms of giving them that sense of meaning, but potentially helpful for their families, or just sounds very meaningful. And is this something that you found is suitable in both the aged care environments and then also in the communities? Is it something that kind of just works well across the board?
Yeah, it's a very versatile kind of therapy, and a lot of research on reminiscence therapy has been conducted in residential aged care, and sometimes often using groups. But there are lots of research projects that have been conducted with community dwelling older adults as well. The therapy can be done one-to-one or in a group format, so it is quite versatile in that way.
And do you find there are any kind of more specific challenges for people who've experienced, for example, they were veterans or things like that, those additional challenges that may mean that someone reminiscing is a little bit more challenging, where there's kind of PTSD or similar?
Yeah, this is a question that comes up at every forum that we're at because it's such an obvious question in a sense. The minute you start to rock the boat, what are you going to encounter? And sometimes families are a bit wary of the counselor, clinician diving in and saying, "Tell me about the past." Because the families actually would like the person to be more in the present, not to unearth old skeletons and perhaps be re traumatized, right, by old wounds. What we found is that that rarely happens. And the reason it rarely happens is that it depends on the approach of the clinician. If the clinician says, "I'm here to ask you about your life, let's start. I'm going to ask you a number of questions and please give me your answers," it feels kind of aggressive and intrusive when you do it that way. But if the clinician says, "Would it be okay if we talked about your past? And I'd really like to know about some of the things that you've been through, some of the good things, but also some of the difficult things. And if you feel the need to take a break or you don't want to talk about things, that's okay too." It changes things completely because now it gives the individual mastery and autonomy over what they talk about. And sometimes we find that this is the first time that a lot of older people have talked about some of the hardships that they've encountered because they don't want to burden their children and families. But here they have a counselor, a clinician who's ready to listen richly to the person's story. And for some of the people that we work with, this is a very freeing experience. So rather than being re-traumatized by the past, our dominant experience has been that talking about the past can be very unloading, can be very freeing, and can provide the individual with a sense of relief and support.
Yeah, that sounds like something that when you're positioning, instead of, like you said, instead of just talking, tell me things, it's sort of more, okay, well, I can talk about myself, I can talk about my experience, and it feels a little bit more natural, perhaps, or less intimidating, especially if they haven't had any sort of counseling in the past or had these experiences with professionals asking questions that might feel a little bit invasive. It sounds really positive.
Yeah.
And
And you've just raised another question, if I may, that when you mention words like counseling or therapy to older people, it comes with certain meanings that we don't always appreciate. These are individuals who lived in eras where asylums were still the place that people were locked up in. And for some of our younger clinicians, it's no longer part of their awareness because we have such a different model of mental health care now. But some of the older people still relate to these images of being electrocuted, going through electrical therapy, or being locked up, or even chained. I mean, these are images that they grew up with. And so the very prospect of seeing a shrink or psychology practitioner is loaded with very negative meanings. So the language that you use as a clinician can be really important. And if you say, "I'd really like to know more about your life history and your life story," it doesn't sound like therapy. It sounds like an interested person wanting to learn from your wisdom, wanting to understand your life history. So it um, can be a very acceptable way of starting therapy with a lot of the older people that we work with.
And I like that you mentioned the autonomy as well. It feels like I can choose what I'm going to talk about and I can choose what not to share. It's sort of tell me what you're comfortable with. And if it's too much, we'll just stop. It's not that's pressure to unpack everything in a 1 hour session. It feels a bit more building that relationship. And I imagine it's important for some of these conversations to have a consistency of the person who's leading the discussions. Is that something that is kind of focused on in terms of the longevity of the relationship? And actually that's a question I have in terms of how long this process would go for. If someone is starting this treatment, how long would that typically span?
Yeah, we found that treatment with older people takes longer. than the treatment typically prescribed for younger adults. The system does not discriminate. It still provides a certain number of sessions under the rebates. But if you're free of the rebates, which I think it only goes for 10 sessions a year, right? So often people try to limit their sessions to 10. But with older people, it takes a little bit of time to build up trust and rapport. And so that might take 3 to 4 sessions where you're not really doing therapy in the traditional way. You're there to present yourself as an authentic clinician, to build trust in the relationship, and to get to know the individual a little bit better. And sometimes the individual doesn't really know why they're seeing you. This is a very different encounter. They're often seeing you as a favor to their families or to their professional carers, and they might say things like, "I don't really know why I'm here, but my daughter thinks I should be, so why not? I'll give it a go." And so it's very important that the start of the treatment begins with that soft touch rather than let's talk about your problems, let's prescribe you with strategies and so on. Once the trust and rapport is built, at that point, the older person typically says things such as, "I think I've got a problem," or "I would like something resolved." And that's often when we enter into a problem solving phase of therapy, where the clinician collaborates with the older person to try and understand what strategies might be useful to address their needs. And here we find that the younger clinician, who is often very much younger than the patient, so think about a 25-year-old clinician providing treatment to a 90-year-old patient, the dynamic is very important. Rather than the clinician prescribing strategies, the task of the clinician is really to draw on the expertise of the older person. And sometimes we find that also is a value of reminiscence therapy, because if you ask questions such as, "How did you deal with problems as they came up in your life? What strategies did you use? What lessons can we use from the past to inform how you might deal with the current situation?" It completely changes the dynamic between the clinician and the client. Rather than the clinician coming across as an expert, the clinician now comes across as an astute and ready listener, there to learn from the client's expertise and life lessons. And as you know, when you're dealing with someone in late life, you are dealing with a survivor. There's no question about it. Through luck or millions of decisions that they've made in their life, they have lived while other people have died. So what you have in front of you is a resource, right? And so that stage of therapy is not only problem solving on the one hand, but it's also drawing on the expertise of the clinician. And towards the later parts of therapy, like I said, because often older people at that life stage are dependent on others for care, we need to bring into the therapy other people, whether it be family members in some cases or professional carers in others, so that those individuals can help implement some of the therapy strategies that have emerged from treatment. So, because of all of those steps involved in treatment, it does take more than 10 sessions. So, it's quite usual for us to find that people are in therapy for 20 or 30 sessions. Now, keep in mind that people are often at the last stages of their life. So, you don't really always have a long time to work with the individual. And sometimes clients do die while they're in therapy. But what we find is that therapy is best done when it's slowed down over multiple sessions and when it's rushed and compressed to the 10 session program that we do use with younger adults.
And when we tie this back to financial well-being and resilience and thinking about the financial implications, does that make it challenging when, for example, 20 sessions is ideal, but they're rebated for 10? Does it just mean that it needs to come out of pocket and perhaps some people can't access it?
Yeah, this is the big problem with our system, not only for older people, but younger ones as well. And often we find people trying to apply ratios to ration their therapy so that they attend therapy once every month so they don't run out of therapy by the end of the year. It's a big problem and we haven't really resolved it. You're absolutely right, because once you reach the end of the 10 session limit under the Medicare program, you are then out of pocket for the remainder sessions. And that's true for the private sector, but it's also true for some of the public services that have a limit on the number of sessions that they can prescribe. And that's why services like ours and others, we don't have caps on the number of sessions that we provide, because we are not funded by the government and we're not funded by the clients themselves. We're often funded by research grants or by philanthropic foundations and trusts. So we can afford to provide that longer treatment that is so essential for this late life population.
Yeah, that actually answers my last question, which was going to be about how does the wellbeing clinic for older adults cater for this? And it sounds like that's something that means you can have those kind of meaningful impact when it's that longer term 20, 30 sessions or whatever feels right for that person. The other question is, from a lifespan perspective, and when we think about adaptive aging, can you talk us through clinical geropsychology and why that's important, particularly when we think about, you mentioned some of the younger population who might be, say, 60 or 70, potentially quite a different conversation to someone who is 90 or 95, and maybe they need different treatment or have different conversations or needs.
Yeah. So maybe I'll answer both those questions. What is clinical geropsychology and what do we mean by adaptive aging? So the phrase clinical geropsychology is virtually unknown, even within psychologists. In fact, if you type in the word geropsychology into a word program, it tries to change it into neuropsychology, which is far more common. So I think that speaks volumes that that word itself is probably not in currency. Um, but what it really means, gero, as in geriatric, as in gerontology, it speaks to the older person. It's a Greek word, I believe, geros, meaning older person or older man, and psychology. So it's the application of psychological theories and techniques to older people. That's really what geropsychology means. Um, and we've been very interested, obviously, in how to adapt psychological techniques to suit the older person. One of the interesting learnings in this field is that as a clinician, you tend to encounter people who are sick all the time, and you forget that there are millions of older adults out there who are living lives that are bright and full and expansive. And in fact, there have been a number of longitudinal studies right now that have tried to answer the question, what makes for successful aging or adaptive aging? What is it that distinguishes individuals who seem to have this full and happy life as they grow older compared to other people who appear quite miserable and stretched, if you like, by the ravages of age? And one of the answers tends to be that it has to do with the relationships that we build throughout the course of our lives. In fact, one of the longest studies conducted in the US, the longevity study, recruited about 700 people, men, in I think the 1920s or 30s, and in that sample you had people who ended up being addicted to drugs, or ended up having broken relationships, or ended up being the president of the United States. So it was quite a varied sample. And they were able to distill what is it about one's life course that predicts successful aging. And their answer was the quality of relationships that you built in the course of your life, more so than diet or even money, that determined how happy you were as an adult. And as we think about aging as a stage in our lives, we start to think about what is the task of older people compared to younger adults. So if we reflect on our own age, as we grew through the different age groups, we were focused on different things. As a child, we were focused on trying to differentiate ourselves from our parents. That's the so-called rebellion phase. And then as we get into our 20s and 30s, our task was to find a life partner of sorts and hopefully find a career that would set us up quite nicely. And then we get to our 50s, which is the most miserable time in one's life, apparently, where we start to question our decisions and we're becoming more aware of our mortality. And then we get to our 60s and 70s, and the question there is, what is our task? What is it that tends to help bolster our sense of self-esteem? And the answer tends to be about leaving some legacy for future generations. And so if you put both of those findings together, on the one hand, good relationship sustains us into late life. And when we get to late life, what tends to help us feel even better is the sense that we're leaving behind a legacy. We can start to understand that older people are moved by different motivations compared to younger ones. Younger people are moved by motivations of autonomy, of making themselves wealthy and their families, taking care of the wealth, taking care of other people. But older people tend to be moved by more esoteric ambitions, How can I leave behind a story, a lesson, a legacy that will outlive my own mortality? And that's why a lot of older people want to write about their lives, write autobiographies, want to tell other people about their life histories and so on. And there are now therapies that are designed, as I've talked about, to try and give people this opportunity. So that's what we think adaptive aging is all about, fostering good relationships throughout your life, but once you reach late life, to think about how you can leave a legacy for the next generation.
I feel like that's a really great place for us to wrap up our discussion today. And I think it's ended being very profound. I think essentially we've covered the meaning of life here. So I think that's all I think it's been really fantastic. And there's a lot of things that I'm definitely thinking about. But what you mentioned around that understanding of legacy, and then also the therapy that really is focused on your memories and remembering things that have happened, that, you know, just gives people a chance to have that dignity and autonomy to share, but also I think hopefully gives them that sense of, oh, I've actually done a lot more than I realized, because now that I'm talking through it, actually I've done a lot of amazing things. And like you said, they're survivors, so they've all done lots, and, you know, they would have experienced a lot. And I think it's probably, I'm sure the clinicians are learning so much. It would be, I can imagine how many stories they're hearing. So really, thank you so much for your time today. And I'll hand back to Vinita to conclude our session, but this has been really fantastic.
Thank you, Anna, and thank you, Sunil. It's been such a pleasure to just listen to your experiences and the wisdom that you can bring to this really complicated question that we asked you at the very beginning. There's so much that I've learned just from this short period with you. And I'm sure that our audience will be able to pick this up as well. You know, the question that we were asking, you know, what is the link between affordability to healthcare? You've answered it in such a great way in terms of it depends on who you are, it depends on where you live, and it depends on what resources you have access to. So that's such an important understanding that it's not just a homogenous group of people that we're talking about. It covers more than 3 or 4 decades of life, and people have different motivations at each part of that subset itself. That was wonderful to really reflect on. Your discussion on treatment models and how they need to be adapted in order to be able to allow people to thrive in older age. I really found that absolutely fascinating, and it's such an interesting area of research. I hope that we can do a bit more on this, because I think we need to develop therapies such as reminiscence that you've talked about. I don't know how many people actually know about the therapy. Everyone's heard about CBT, but really good to hear about how it's bringing value and meaning to people's lives at a time when they're looking to see what is the legacy that they're leaving behind. I really love that. I love the fact that you said that it actually gives autonomy to people. And even those who've had traumatic, maybe negative experiences in their life can benefit from thinking about what are the good things that they have had in their lives. And that helps to reduce depression and anxiety. So that was a really great way of looking at strength-based initiatives, because Anna, myself, and the whole world of financial well-being always looks at strengths-based approaches. So to hear that in a mental health context was absolutely fascinating. I really love that. And the last lesson that I can have from this is being able to contribute to help older people to see the value that they have created, no matter which stage of life that they're in. So thank you so much once again, Sunil, for sharing your vision, your passion. On a purely selfish note, I really hope that as part of my ambition to help in that mental health journey for people, that I can help to contribute in some small way to the fantastic work that your clinic is doing. So I take this opportunity to congratulate you once more for the fantastic work, practical as well as research insights that you're generating, and hope that we can bring you back at a future point in time to talk about the success of some of the new models that you're looking at. Thank you so much, Sunil.
Great, thank you.